Um, Great. Well, welcome everyone. My name is Darshan Mehta, and on behalf of the Osher Center for Integrative Medicine, we welcome you here for our March Grand Rounds. So we're very excited today to present Dr. Suzanne Hanser, who is the chair of the Department of Music Therapy at Berklee College of Music. And she'll be presenting her thoughts on integrative health through music therapy, research practice, and demonstration. So we're really excited. And she has invited a dear friend and colleague of ours, Dr. Robert Saper, who is the founder and director of the Boston Medical Center Program for Integrative Medicine and Healthcare Disparities as a discussant. So really excited to have. Just wanted to quickly those of you, in case you may leave early before the end, just want to let you know that on this Thursday, March 3rd, we have a phenomenal presentation on the evolution of chiropractic research from mechanisms of subluxation to comparative cost effectiveness. And that'll be from 4 to 5 in the Shapiro breakout room here in this building. As well as next month, our Grand Rounds is going to be from our colleagues at Boston Children's Hospital, doing a clinical case presentation on family-centered integrative care in a pediatric hospital, an interdisciplinary model. So again, thank you all for coming. We look forward to a fantastic presentation. Dr. Hanser.
Thank you so much, Darshan, and thank you all for coming. I am going to be speaking about 4 decades of a research agenda. I know I don't look that old, but I actually published my first research article as an undergraduate. And as I was reflecting on which studies to present to you today, I realized that I've spent approximately 1 decade in each medical specialty. And my mission has been to develop new music therapy protocols. I've really allowed these to percolate over the years and to evolve in some unusual ways. And so I'm going to give you a whirlwind tour of my life and also of music therapy. So I don't know how many of you know about music therapy or have had the pleasure, I hope, of having a music therapist at your facility. But I like to say that music therapy is using this incredible modality to bring the melody to heart. So the melody is immediately offering images of times past when maybe I danced to this music with my first love, and the occipital lobe is going wild as if I'm there again, yeah? And then the harmony will bring in, well, a direct access to the limbic system. It's really monitoring our mood and moving it slowly, and sometimes not so slowly, moving it around. And then the rhythm, the basal ganglia of our heartbeat and our circulation really allows us to respond to music in a visceral way. And indeed we do, whether it's rock or rolling or jiving, but we are moving to that music in our minds and in our bodies. So I'd like to start, perhaps appropriately, at the beginning of life and talk about some research in childbirth. I had the pleasure of working at Damron Hospital and working with women who were about to give birth and wanted to do some research in this area, but when I did a power analysis, I realized I would have to devote a few decades of my life to be able to detect a difference. I would require such a large N. However, the repeated measures design, using these women as their own controls, was very inviting because I could compare them during labor when music was playing and when music was not playing. But this was more than just playing music, and music therapy is indeed something that's different than playing music. As you saw perhaps in the last slide, a board-certified music therapist who trains clinically as well as academically, has 1,500 hours of supervised practice before sitting for a national board certification exam. This is a bona fide field that's evidence-based. Our protocols are based on a growing body of research, I'm happy to say. So this study was the first in obstetrics, and as a result, it was difficult to know what I could actually observe. I wanted to see if music could affect relaxation. But are you relaxed? I have no way of knowing. If your body is still, that hardly means you're relaxed. But a more straightforward way of observing these women in labor were what I call pain-related behaviors. Those are rather straightforward, yes? Vocalizations of pain. You can imagine what those might have been like. Then there were, of course, body tension, fists, grimaces, tight eyes, flexed feet. Those were very easy to observe. Shifts in position and requests for medication. And so during 10 contractions, music was playing. And this was not just any music. This music was conditioned to produce the relaxation response. This music was music they had practiced along with their prepared childbirth breathing techniques in the comfort of their homes, with their coaches, and uninterrupted when possible. So they practiced finding very meaningful music in their lives, music that had great associations and memories associated with it. They practiced deep breathing to slow music, and I actually ordered these pieces of music that they selected according to tempo, starting with the slowest and moving on to very rhythmic music. And as they practiced different breathing techniques, this graph actually shows the breath. So there's with this slide breathing, they're taking a deep inhalation and then exhalation. And in this example, I think you can see how music actually cues that breath. Hi.
I was cheated by you, and I think you know when. So I made up my mind, it must come to an end. Look at me now, will I ever learn? I don't know how.
So you get the idea, yes?
Lose control.
And look what happened. During labor, those pain-related behaviors measured for each subject, and this was a small study, in each case, the pain-related scores were greater when music was not playing. Obviously, a very statistically significant result. And this can perhaps be best described by the neuromatrix theory of pain. We're literally bombarding the brain with these stimuli. It's music, yes, and it's cued breathing, but it's also the associations, the memories, all of that music brings. And while these neurochemicals are flooding the brain, there are a number of domains that are at work here. So the pain becomes diffuse and spread out. And as the music is going, we're looking at the sensory discriminative domain here. And the motivational affective domain, when that imagery comes to mind, you're really there. The occipital lobe is amazingly active. And the evaluative cognitive domain is really dynamic when we reframe pain, seeing it change as we are breathing quite rhythmically. And these results are supported by several Cochrane reviews, one on music and pain, and that looked at 51 randomized controlled trials. As you see, some real changes in opioid use and also preoperative anxiety and pain. In the cancer realm, another Cochrane review shows similar changes, increases in quality of life as well. So, very quickly, we'll go to the other end of the life cycle, to geriatric medicine, where I had the pleasure to work at Stanford University when I had a National Research Service Award through NIA, and worked with Dr. Larry Thompson on a protocol that NIA was very interested in developing for homebound elders who were isolated, who could not come in to the Center for Psychopathology and Aging at Stanford. Would you like to walk through those doors? Fortunately, they changed the title to Older Adult Research and Resource Center. But anyway, it was the Center for Psychopathology and Aging when I was a postdoc. And we recruited individuals for a number of research trials. And I got the leftovers, those people that could not come in for treatment because they were caring for a loved one with some cognitive impairment or physical ailment. Perhaps they themselves were ill. Many were indigent, couldn't afford the transportation costs. And so for a variety of reasons, I had a large sample of homebound older adults who had clinical levels of depression. So they had mild or moderate depression, and I decided to do a randomized control trial. And this was an opportunity for me to make home visits to these individuals, teach them my new music therapy protocol over 8 weeks, 1 lesson per visit. And I knew that social support was going to be a very important factor in these older adults and in relieving their depression. So I knew I had to control for my presence. I therefore had another condition where I never met these people. We made a phone call and spoke briefly about how they could develop what now would be known as playlists for each of these musical lessons, if you will. And they received a typewritten 2-page instruction booklet each week. I wanted to look at several variables here: anxiety, depression, mood. Brief symptom inventory proved to be a valuable way to really look at what was going on globally with these rather isolated older adults. And I developed this protocol based on using music with the body. The first 3 exercises involved moving to the music, doing a gentle facial massage, and doing what I call musical muscle relaxation, a tensing and relaxing, just like progressive muscle relaxation, but again, cued by the music. And then using imagery, guided imagery in the 4th lesson. The 5th involved what I call creative problem solving, using this imagery to actually envision yourself doing something that you've avoided, or just getting out of bed and beginning your day. The last 3 were emblematic of the kinds of impact that music therapy has. Deep relaxation, using it to help you sleep, finding music that's important to you, but also deeply relaxing. And then musical entrainment involves finding music that matches your mood and slowly changing the elements of that music, so that if you're feeling extremely lethargic, we would start with very slow music, perhaps very sad music, and then slowly find pieces that were of a tempo that is increasing, perhaps going from certain modes or minor to major, but again, all selected by this individual. And finally, in the last exercise, they were encouraged to find new ways to use music in their lives, to do some artwork, or just to do the dishes with the music, whatever they could do to bring more music and other pleasant events into their lives. And this is what occurred. This is the geriatric depression scale. And as you see with the circles, the home-based and minimal therapist conditions both yielded, and these were significant changes. The triangles in the control group stayed relatively the same, but both music conditions at 8 weeks differed significantly from the control. And 9 months afterwards, when the same measures were instituted, again, this one, the geriatric depression scale, there were maintenance of gains in both, and the minimal therapist condition actually continued to improve. Theorizing here that locus of control was evident, that people were taking control of their lives, seeing that with a simple music intervention they could actually change their depression, their symptoms, their mood. This is the profile of mood states. Higher the score, the more composed. The lower the score, the more anxious. Once again, significant differences between both music groups and the control, and continued gains over a 9-month period. These outcomes, all of the measures were statistically significantly different from the control group with the music groups, and at the 0.05 level. But perhaps more important to me, at the end of this 8-week protocol, these depressed older adults more closely resembled a non-depressed sample of elders. And these changes, therefore, were clinically significant. Maintenance of gains was also very encouraging, that this was a protocol that could be used by elders independent of any intervention by me or a music therapist. So I'm bringing to you today a few cases, and this one was a woman who, as you see, was depressed due to bereavement. In fact, she had lost her husband 2 years prior and was quite dysfunctional, unable to really get out of bed and to even do the simplest household chores. And she found this song called Remember. It's Irving Berlin, Billie Holiday singing.
Remember the night you said, I love you. Remember you vowed by all the stars.
So this song was very important because this was a song that she had loved. With her husband, they danced together. They knew this song well. They sang it to each other. She felt that listening to this song would really make her more depressed, but she surprised herself and found that listening to this song brought him back to her. She felt his presence, quite literally, and she listened to album after album of songs that were special to her. In this case, we were really looking to enhance the pleasant events in her life, and this became an immensely pleasurable time. This again was a CBT approach, cognitive behavioral therapy, where we're conditioning the music to these other behaviors, deep breathing, muscle relaxation, imagery that's positive, bringing back those memories. And what's really unique about music is that the auditory memory is quite robust and persistent. Auditory memory is, well, it brings back episodic memory, yes, but those memories are deeply embedded in the limbic system. And the paralimbic, the limbic system, the basal ganglia, the motor cortex, all of these areas, even parts of the cerebellum with irregular rhythm, are activated and flooding the brain, if you will, with positive stimuli. So let's go on to oncology. Another decade ago, and I was very fortunate to work at Dana-Farber Cancer Institute as they were developing the Zakem Center for Integrative Therapies. There's a wonderful music therapist there currently, and a whole team who work in the Jimmy Clinic and Children's Hospital as well. And I was very interested in working with some of the populations there that were in greatest need, and worked with a wonderful team, and decided to focus in on women with metastatic breast cancer. So we conducted a randomized control trial using music concurrent with chemotherapy. And it was an individualized approach where we were looking, number one, in the first chemotherapy session, to merely help them relax. And I just brought a lot of instruments, which you will see in a moment, bedside, and offered these pieces of music based on just my observing their breathing rhythm. I used things like the Native American flute. I used things I could carry with me, a dulcimer. It's quite easy to play. And very gentle sounds that offered an environment where they didn't need to do anything, and they could close their eyes and perhaps imagine a place they would really rather be. And in the second session, during that next chemotherapy, I invited them to play with me, to create a soundscape. And as you probably know, the acoustic environment there is quite bright. The glass, the stainless steel, allow sounds to reverberate. So we use very resonant instruments, percussion instruments, soft percussion, not large drums, as you can imagine, because the sound does travel. But you'll see someone using some hand chimes in a very creative way. And in the third session, I invited these women to create a song. And many of them created a kind of lasting legacy, something about themselves, something about loved ones. Most poignant, I think, were the songs that were written for someone else, to someone else. And here's an example of one woman in an interview about the research.
Is tuning out her breast cancer and tuning into music.
I have had my cancer for 14 years now, and I have gone through almost every single chemotherapy that's available.
A few months ago, Nancy enrolled in a study at the Zakem Center for Integrative Therapeutics, looking at the benefits of music therapy on the quality of life of breast cancer patients.
Two particular notes that you play on each side of me, and I was between them, and I felt all alone in a very big space.
I think music is something we all take for granted. Music can give them a way to relax. It can give them a distraction from pain. It can offer them something to enhance the quality of their lives.
As part of the study, patients get to make music, empowering them to take control of both their mind and their body.
So you see there the hand chimes, which were quite resonant and quite beautiful. And I only offered those tones that belong to the pentatonic scale. So if you know that, that's the black keys on the piano. And a whole note is the smallest distance between any two notes. So you can play them together, and they really sound quite sonorous and consonant and beautiful. So we looked at quality of life I'm moving to outcomes here. We looked at immediate effects before and after each session. We looked over time, and most of these interventions were over a 3-month period with chemotherapy sessions monthly. But actually what happened was in these very ill women, many of them were unable to tolerate chemotherapy, and so there was a great deal of dropout, and many were having chemotherapy maybe once every 3 months or so, so they were excluded from the study. But the immediate outcomes were significant, this at 0.05, and looking at a visual analog scale just prior to and at the end of each session. And looking at heart rate, this was also decreasing from the beginning to the end of each session. We looked at patient comments in an open-ended question, and as you see here, the benefit that was cited most was relaxation, followed by enjoyment and coping strategy, even down to gives me more energy, is a transformative experience. All sorts of really rather amazing sorts of outcomes that you might even consider in the spiritual realm, if you dare to try and assess that. Well, I'll tell you about one woman who was a bit resistant to music therapy, frankly. I'm calling her Music Is Here For Me because she wrote a song with me. Despite her resistance, she said, "Oh, I could never write a song." And I said, "Well, let's try it. I can write a song, and maybe I can show you how you can express something you'd like to express. Is there something you'd like to say about what's been going on in your life?" She said, "No." "Well, is there a loved one you'd like to say something to that you just haven't had an opportunity to say?" And she said, "No." And I said, "Well, perhaps there's something about the music and our experience together." And I had a guitar with me. I was just strumming a simple progression. I started to just hum a simple melody, a song without words. And she came up with these words, this music. "The music is here, the dancing is here, back and forth we go. It's helpful for you, it's helpful for me. The music is whoops. Oh yes, it's hard for me to read. The music can save me. It is here when I want it, it is here when I need it. It will be just right for me." And she reflected that in a comment at the end of the research. Been looking for a tool to use as an antidote for pain and tension. Music is a wonderful choice. It makes me feel more secure and optimistic. I truly believe it will help me. And just then, she was in the garage having a panic attack because the venipunctures that were required at every visit were just so difficult for her, and she just couldn't really stand that experience and tolerate it very well. She closed her eyes and spontaneously began singing the song that we had created subvocally in her head. And she said, "I opened my eyes, the blood was drawn, everything was over, I hadn't felt a thing." So you see that there are some powerful coping techniques that we are teaching people by engaging them in specific strategies, not just listening, not just engaging in music, but truly finding a way to find themselves. And here's a gentleman with leukemia, also from Dana-Farber. He was instrumental, if you excuse the expression, in his own therapy. He found that when he came in for his visits, he was not Brad. The physician, the nurse, wouldn't say, "How are you, Brad? How are you feeling today?" They would say, "What are your counts today?" He was identified by his counts, white blood cell counts, every visit. And this determined whether he would require treatment, whether he was declining, whether he was getting better. So he created something behind the numbers, and this is created by him. And he went on to also put his red blood cell counts and platelets to music. He actually used an algorithm at the University of Washington that does this for him, and created some rather beautiful pieces of music. Again, reframing the experience of illness. In this case, the resilience model put forward by my colleague Sherry Robb in her work at multi-site cancer centers, looking at the use of creating music videos for transplant patients, supported this resilience model whereby defensive coping is transformed into courageous coping. And illness is really, in a self-transformative, self-transcendent process, changed into making meaning of what it means to be ill, what it means to have these numbers, and how I can create things. So now we're up to current time, and it's my great pleasure to collaborate with an incredible team at Boston Medical Center in the Family Medicine Unit. My dear colleague, Dr. Rob Saper, is here, and our research coordinator, Eric Rosine, is here as well. And we are in process with a feasibility study to look at the influence and mere feasibility of introducing music therapy, and in this case, massage therapy in the Family Medicine Unit. Dr. Saper had plans to engage in a controlled trial of massage therapy, and I don't know how, but I convinced him to add an arm for music therapy, and we had usual care. We were really trying to look at the triple aim, the very important patient experience as well as their health outcomes that affect cost effectiveness, like length of stay and, as you see, pain medication, symptom relief, patient satisfaction. We randomly assigned people to music therapy, individual sessions, massage therapy, or usual care. And I thank Dr. Rosine for putting together some of the demographics. This is such a heterogeneous group. This is a diverse sample, as you see, ethnically, and we looked at length of stay and pain medication, not showing any real differences here. But as you see by the admission diagnosis, these people were tremendously different in their reason for being hospitalized. They also had many comorbid conditions, substance abuse, and many of them were indigent. So you can see why we are still looking at those results. But I want to show you how the development of a music therapy protocol came together with this intervention, whereby we were looking at first offering a personalized CD that each patient could use during the time that they were hospitalized. And they created the label, the title of the CD. They also worked with the music therapist who did an assessment to determine what their favorite songs would be, and also those songs that had positive memories and associations could really bring up some beautiful images for them. And then they were given a CD with various instructions to help them to relax. In the second phase, you can see there were three possibilities. For those who were more courageous, perhaps, they were engaged in more active creating of songs, and in the process, looking at the lyrics of an important song to them, analyzing those lyrics, learning some relaxation strategies to use along with that, using energizing techniques, a whole variety based on their particular needs, and hopefully ending with songwriting. So I'll share with you two cases. One woman here with sickle cell disease who was in crisis, and in fact a huge outlier with, I believe, a 36-day stay in the hospital to try and get her pain under control. She created this CD called Relieve, And that beautiful scene was where she wanted to be. With the help of the music therapist, she created this song, and I'll play an excerpt for you, sung by the music therapist.
Live my life as if I only had today. I keep strong when life throws hardships my way. No fear, no pain can keep me down. I will get up when life wants to push me down. With God and love on my side, laughter of children bringing joy to my heart. No fear, no pain can keep me down. I will get up when life wants to push me down. I will get up. Get up.
A rather existential opportunity to look at the meaning of her illness and bring hope to it. And these were all her words. Similarly, with a gentleman who was morbidly obese coming in with cellulitis, he had some anxiety disorder as well, and he was having a hard time falling asleep. So his songs were to help him relax and sleep. And the music therapist created this CD for him. He was a trained musician, and so he grabbed the music therapist's guitar and wrote this song and is performing it here for you.
My life right now is pretty much on hold. My time is spent waiting to heal. I feel stuck on an island, watching others sail by, their lives moving forward, while mine is still standing by. Trying to find the music within the noise, the eye within the storm, a calm inside the tension, the peace inside the war. What used to be easy.
The calm inside the tension, the peace behind the war. I think you can see some of the profound outcomes of this creative process. We're really helping people to find their inner creativity, their inner resources, their resilience, and to express themselves and to find the hope and the peace and all of these things that they themselves discovered in this creative process. So I hope that you have seen how feasible music therapy can be in a variety of medical settings, that it is indeed evidence-based, that our protocols are based on a variety of underlying mechanisms and theories. And we really hope to do more research in the area of finding those mechanisms that explain some of the profound changes, the transcendence that people report in this work. The assessment of these outcomes is very challenging, and I welcome your assistance in helping us find the way to measure quantitatively some of these qualitative changes that we see. And we also want to identify who is it that is most responsive to music therapy. There's no clear answer. Often we're surprised by the people who respond the most. And I'll leave you with the words of Khalil Gibran. O music, in your depths we deposit our hearts and souls. Thou hast taught us to see with our ears and hear with our hearts. Thank you very much.
Thank you, Suzanne. That was terrific. Just a couple thoughts before we open it up. I was extraordinarily pleased when Suzanne approached me and we talked about integrating music therapy into this inpatient study. The origins of that study were to try to determine whether therapies like music therapy can truly contribute to the triple aim of healthcare: improving patient experience, improving health outcomes, and possibly decreasing costs. I want to just share another case that occurred in the context of this study. I happen to have been attending on the family medicine inpatient service during this period of time. And late one evening, we had a gentleman with alcohol withdrawal who was extraordinarily agitated as he was withdrawing from alcohol. And despite being given sedatives, there had been a couple times where he had to be restrained, 4-point restraints. And that's something that we take very seriously, we don't like to do, and it really should be avoided at all possible costs and only done when safety is an issue. I happened to have been there when he was quite agitated, and because we were doing this study at this time, the music therapist, Maria Hernandez, also happened to be on the floor. And so I called a STAT music therapy consultation, and Maria came in and worked with this gentleman who had altered sensorium with music, with her guitar, to try to help calm him. And he was able to calm and not have to have 4-point restraints and not to have an injectable medication. And so that was, a profound example for me about the utility that a therapy such as this can offer. I want to make 2 points that I took home from working on this project. One is the power of interprofessional collaboration. We represent here a lot of different domains, and we have so much to learn when we cross bridges. When I first met Suzanne a number of years ago, I didn't know what music therapy really is. When you hear about it, you think, well, it's listening to music. But I think, as you can see from Suzanne's presentation, it's far more than that. It's patient-centered. It's eliciting what's important for the patient. It's improvisation, music making. It's associated mind-body techniques like deep breathing, muscle relaxation, and really has a tremendous power. So just such an incredible opportunity for us to meet others from other disciplines, learn from them, and try to advance healthcare at the same time. The second point is really a question to all of us. As I think you saw from some of the cases here, there is tremendous meaning making for these patients with illness that are hospitalized through music therapy. And certainly, unto itself, in an isolated format, it's beautiful, it's wonderful, it's incredible. The question is the inpatient setting, is the hospital setting, is that what we're supposed to be doing? Is that necessary? And how can we work with hospitals and healthcare settings like where we are right now to try to demonstrate that something like music therapy is actually necessary and needed as a part of healthcare? I mean, it's certainly very powerful what we watch here, but is that going to convince a CEO, et cetera? Is it through the lens of patient experience that we can promote something like music therapy? Are there outcomes like the ones that you've been shown here that can persuade folks? Because I think we're really at a critical time. Music therapy is low-hanging fruit for a complementary integrated modality, but how do we demonstrate through research or through projects its necessity and its potential role to really advance healthcare? So I'll just leave it at that and open it up for questions and discussion.
Okay. So, yeah, absolutely. Great. Okay, well, first of all, thank you to both of you. Thank you, Suzanne, for a fantastic presentation, and thank you, Rob, for your comments. So, yes, we wanted to open it up to questions to the audience here. So, yeah, Gary. We're going to just pass the mic so that people can hear.
Thank you. That was inspirational. I'm a chaplain here in the hospital. I see patients on the oncology ward. Some of them are in treatment. Some of them are at the end of life. And during your presentation and in response to Dr. Saper's question, I wonder whether you've done any inquiries, let's call it research, about how music has helped people in the end of life transition, whether music can be part of a legacy that they can leave, which is such an important part of EOL, and whether it eases that transition.
Indeed, there are a number of music therapists who are working in hospice and in palliative care. And much of the work are legacy projects that are, again, similarly, existential journeys through life, finding meaning, finding a way to communicate to others what their lives have meant. Moment. So there is a growing body of research that is looking primarily at relationship between family caregiver, family members, and people at the end of life. That is quite convincing that this opens up a channel for communication to others. So there is a good deal of data as well as enormous amount of anecdotal information about the inspirations and transcendent ways of changing the sense of meaning at the end of life.
Yeah.
Thank you very much for that presentation. I'm curious, when you were talking about the effects on pain management, whether anybody has done fMRI studies to see what is happening there. You know, that would seem to be a fairly clear thing one could measure.
Yes, there are fMRI studies, one by Ann Blood at MGH, who has looked at the impact of music that gives you chills, and has found that the reward mechanisms in the brain are activated, and so those many areas of the brain that involve the imagery, it involves memory, involves emotional change. All of these things are strongly affected by music that really has meaning, gives you chills.
Thank you so much for your time this morning. I wanted to sort of think through the question that you're asking, like how do you make music therapy or things like this more integral to the healthcare system? And I feel like I've heard music therapy and collaborative music making and creative processes being more proactively accepted in other countries, like England and, you know, like Nottingham. And just wondering, like, what you think are the particular challenges in the United States that we face.
Rob, maybe you can start.
Well, you're right about the cultural differences, that music is such a part of community in other cultures. In the West, we sit and we listen and we behave ourselves. We don't dance along in the aisles unless we're given permission. And so here, music has a very specific function, and it is art music, or it is the music that we can plug ourselves into and have an individual experience, and that's okay. But when we bring it into a hospital setting, well, it's music. I mean, why would we need to hire a music therapist? Why would we need to do anything more than just allow music to be played in the hallway? But as you see, there's really a functional use of music by an expert in the field that creates the most maximum effect. I'm sure you have some thoughts about the healthcare side.
Some other countries, there's a greater acknowledgement of the importance of the healing environment, the environment that a patient is within, and how that can affect, their rehabilitation. And so it really comes from a biopsychosocial model of health and illness. Although in this country we have come a long way beyond the biomedical model, I think the case of the patient who is receiving the chemotherapy is very telling. The patient comes into the clinic and they want to know what the white blood cell counts are. And so these kind of quantitative outcomes have a tremendous supremacy in our healthcare system above the subjective, the feeling, et cetera. And I think that's one of the barriers here that we're slowly working against.
Rob, I was wondering if you could comment on what your colleagues' response was when they saw one of their patients in this, particularly maybe in the study, go through a music therapy experience. Did you hear any stories from your colleagues?
Yes, one of the exciting things that we observed, and one of our goals was there was a cultural or attitudinal shift on the floor. So there is a certain culture on an inpatient floor. We're very fortunate in that we've gotten to know our nurses and nurse managers because it's our floor that we always work on. But the nurses particularly became more interested in, coming up to us and say, oh, this would be a great patient here for music therapy or massage therapy, very deferential to the music therapists. But at the same time, they have a lot to do. They're very busy, so they appreciate it. It's going on, but they're also busy doing their things, and so it does prevent them somewhat from deeply engaging.
So going to the other end of the spectrum of healthcare prevention, is there anything happening or what has been happening using these concepts of music therapy in a preventive mode? Violence reduction, avoidance of drugs, all kinds of things I could think of where music might be a preventive treatment.
Well, we certainly have a number of community music therapy programs and a lot of advocacy work with young people to get them engaged in musical activities at the Girls and Boys Clubs, to get them engaged in joining a band and taking music lessons after school instead of wandering around and being idle. So there are many possibilities that are unfortunately not supported and funded by local communities very much. We need outside funders to look at working with young people through music, giving them an outlet and a way of expressing themselves that's perhaps more socially acceptable than other ways that they use on the street. So there's much evidence that there's potential here, but we need for communities and politicians, it is election day, to support these sorts of activities.
You mentioned a couple of times a protocol, I guess sort of your developed protocol. Can you say anything about how that developed? Are protocols standardized across therapists, across studies? If you look across studies, what conclusions do you come to about generalization, so on?
Right. So one of the challenges in our research is that there are many different ways of creating music and of implementing music therapy techniques. And there are some that are quite improvisational and difficult to standardize. There are others, like mine, where I've attempted to give very specific instructions on how to use this music. And often people are finding their own ways, like in the case of Brad, to use music. And that's very challenging to a research environment, but very encouraging to someone who wants there to be more music in people's lives and for more people to use music in a functional way. I think as music therapists, we're really teaching people how to listen to the music and to the effect that it has on them. It's not just about the music.
So we wanted to invite everyone to continue this conversation just across the hall in our coffee hour. And just as a one of the exciting things about this coffee hour has been that we've become a very rambunctious crowd, it sounds like, because of some of the stimulating conversation that has begun in this. So we do want to continue that stimulating conversation, but just we've been asked to just be aware of the immediate surroundings. So
no music.
No, well, we can. Yeah, maybe we can bring out. I was thinking we could have a drum circle going, but again, wanted to just remind everyone. This Thursday, again, a very stimulating conversation on the evolution of chiropractic research from mechanisms of subluxation to comparative cost conduct. And this is going to be, this talk is going to be given by Matt Kowalski, who's the chiropractic care provider at the Osher Center for Integrative Therapies here at Brigham. And then next month, our first Tuesday, April 5th, we will have our colleagues from Boston Children's Hospital giving a clinical case presentation on family-centered integrative care in a pediatric hospital interdisciplinary model, and that is going to be presented by several presenters who's there's a handout outside as well. And then once again, we wanted to really thank Dr. Hanser and Dr. Saper for, again, a fantastic, wonderful presentation. We look forward to hearing more and seeing the research emerge, and look forward to continued success in this important work. So thank you.
Thank you all.